on the antibiotics to use and how long to use them. As a means of etiology, we're looking at the etiology of post-operative fever. This can actually be divided into 5 causes, and it goes with the acronym of the 5 W's. One is wind. Wind stands for respiratory tract infection, which most commonly is atelectasis, can be seen as pneumonia. Next is water, which stands for urinary tract infections. Following that is wound, points towards surgical site infections. Walking, which stands for deep vein thrombosis and pulmonary embolism. Thrombosis is seen mostly in the calf. Then wonder drugs include drugs and blood products. Drugs, they are looking at how patients react to certain medications. It has the umbrella occupies both malignant hyperthermia, serotonin syndrome, malignant neuroleptic syndrome, all these drug reactions that happens in patients during post-operative care. Blood products here, we look at blood transfusion reactions or drugs. These all falls under wonder drugs. Now, etiology based on time of onset. We will be breaking into that classification I mentioned earlier. For immediate fever, that's fever occurring within the first 24 hours, 0 to 1 day. We'll divide into 2. This fever could be less than 38 degrees Celsius. And here we'll point towards metabolic response to trauma. This trauma could actually even be the surgery that the patient underwent through. The body could just respond to it, produce cytokines because of the whole injury going on, the inflammatory process is going on, and it will cause fever. Meanwhile, not that there's any actually ongoing infection. Another could be malaria fever. When the patient, after post-op, it could also develop malaria, be it from the blood products he received or during post-operative care. Now, when this temperature is above 38 degrees Celsius, like after post-procedure, the patient is told to have a temperature of 38.5 to 39 degrees Celsius. What our mind is looking towards is the wind and wonder drugs. These are really the ones that present earliest. And a very common one here is atelectasis. Another is blood transfusion reactions. We all know that during the patient can receive blood transfusion during the surgery, and even while in the recovery room, he can begin reacting to that blood. Another one is drug reactions. I mentioned some drug reactions, the serotonin syndrome, the malignant neuroleptic syndrome. All those, even malignant hyperthermia, that can occur on table when patients react to general anesthetic medications. And that could be pre-existing condition associated with the fever, as seen in patients with thyroid storm after thyroidectomy. Second, we'll be looking at acute fever. As I said earlier, this fever that occurs between the first week post-op, that is between day 1 and the first week. In this aspect, I want to divide this into sub-sections. For the first one, looking at the day 1 and day 2 post-op, wind and wonder drugs still fall under this section. And this also includes aspiration pneumonitis, especially in unconscious patients, indwelling catheters, drug fever, seen as drug reactions, and also transfusion reactions. For day 2, we're looking at wind and wonder drugs still. Here, pneumonia sets in, wound cellulitis, necrotizing fasciitis, and clostridial myositis. Day 3 plus, that is between day 3 and day 7, we're looking at systemic causes. Here, we're now looking to walking, water, and wound. Here, patient will have thrombophlebitis, maybe from the IV insertion site. Deep vein thrombosis or pulmonary embolism. Pulmonary embolism is actually like a complication of the deep vein thrombosis when the clot is dislodged. Urinary tract infections, when the however is advised that catheter is removed as soon as possible. Wound infections, septicemia, fungemia, and viremia. Day 7, that is at day 7, also looking at surgical complications, which will include wound and walking. Here we're looking at leaking anastomosis, post-XLAP, infected prosthesis, deep wound infections, abscesses, especially intra-abdominal abscesses, and still deep vein thrombosis. For subacute fever, which is fever occurring between week 1 and week 4, we're looking at here wound, walking, and wonder drug. This includes surgical site infection, thrombophlebitis, deep vein thrombosis or pulmonary embolism, drug reactions still, and also intra-abdominal abscess. For delayed fever, this fever after 4 weeks, most likely patient has been discharged and doing follow-up clinics, patient come and present with fever. It might be from skin or soft tissue infection or viral infection that may occur. Now, etiology based on infectious and non-infectious causes. For non-infectious causes, we'll be looking at systemic inflammatory response syndrome. This actually can happen in response to trauma, hematomas, especially subarachnoid hemorrhage, medications too, like anesthetic medications or some antibiotics, deep vein thrombosis, transfusion reactions. These are non-infectious causes. Now, infectious causes surgery related. We're looking at wound infections, intra-abdominal abscesses, leaking anastomosis with peritonitis, infected prostheses, transfusion-related reactions. For infectious causes still, but which are not surgery-related, we're looking at malaria, pneumonia, pharyngitis, laryngotracheitis, decubitus ulcer, that is a complication which when a patient has prolonged hospital stay. Then organ-specific infections, which includes meningitis, hepatitis, parotitis, and or osteomyelitis. The pathophysiology of post-operative fever. Infectious or non-infectious etiologies elicit the production of pyrogenic cytokines, which is the final common pathway through which fever occurs. Infections causes an inflammatory response in the host to invasion by microorganisms and their toxins. Here, we're looking at patient getting infected with microorganisms. These microorganisms stimulate the immune response, whereby proteins which they express. For gram-negative bacilli, we're looking at their lipopolysaccharide cell wall, which contains these pathogens. But for gram-positive cocci, we're looking at the exotoxins they produce, like the peptidoglycan. When they produce these pathogens, it stimulates the immune system. These toxins stimulate monocytes and macrophages that produce pyrogenic cytokines, which includes interleukin-1, interleukin-6, tumor necrotic factor alpha, and interferon gamma. Now, important among these cytokines produced is interleukin-1, which is the prime activator of febrile response. And it acts by going to the preoperative nucleus of the hypothalamus and the circumventricular vascular organs, resulting in production of high level of prostaglandin E2. It is actually produced with COX pathway, or dizziness pathway. Now, this prostaglandin E2, what it does is that it now acts on the thermoregulatory center of the hypothalamus and raises the temperature set point in the body to a higher level. Causes fever in the body. Effect. Prostaglandin E2 does that effect on the hypothalamus. Now, on evaluation of post-operative fever, I have a patient in the ward and the procedure has been done, and then I've been called that this patient is having fever. How will I approach this patient? My differentials in mind based on maybe the timing or possible causes or how the procedure went through, and also how I will manage this patient. First, we want to start with the history and physical examination, because post-operative fever depends highly. It depends a lot on underlying cause. Infection as a cause is best diagnosed with specific symptoms and signs attributable to the infection. Evaluation takes into consideration what type of surgery this patient will undergo. As a surgeon, what did I encounter in the surgery? What's the immune status of these patients? Am I dealing with immunocompromised patients that I know that, even nosocomial infections and other ones, patient is very prone to it? Or this patient is actually meant to be in isolation? Or this patient had an underlying primary disease, like a patient that had a thyroid mass that that thyroidectomy was done, and suddenly the patient developed the fever of almost 39.5. This will actually give a pointer to what's happening in this patient. Also, the duration of hospital stay. How long has the patient stayed post-op? Or the epidemiology of hospital infections. How long has the patient stayed post-op that warrant them developing fever? Also, when talking about epidemiology of hospital infections, here especially in the African region, now, malaria is very common. Most patients that develop fever here will actually be a pointer towards malaria fever. So bearing these 4 points in mind, the type of surgery, the immune status of the patients, underlying primary disease, duration of hospital stay, which help in the which or the 5 Ws to use based on timing, and also epidemiology of hospital infections. If there's an ongoing epidemic around, that could also be a pointer to you, like when we had COVID going about. Now, for the history, looking at the symptoms of these patients, if this patient is complaining of pain at one side alongside with the fever, we're looking at those most likely a wound cellulitis or a surgical site infection. If the patient is complaining of headache, chills, rigor, arthralgia alongside with the fever, we'll be tilting towards malaria. If you're looking at the complaint of cough with sputum production, dyspnea, chest pain, we're looking at pulmonary lesion. You could have maybe atelectasis or pneumonia. We're looking at absence of voice, cough, throat soreness. This is mostly seen when patients undergo intubation. It's really difficult intubation. And most especially when it comes to double lumen endotracheal tube. Patients may actually develop soreness of the throat and cough and hoarseness of the voice. because of the whole manipulation that may occur. So this might be a pointer too towards what's happening in these patients. If they are developing frequency, urinary scaling, and frank pain, and this patient is also on catheter, we're looking towards urinary tract infection. Even though there's an examination part of the urine bag and the tubing, it also comes when you look if there are plaques there or the type of urine in the bag. Let's complain of abdominal pain, abdominal swelling, constipation, diarrhea. We're looking at an abdominal cause. Is there a peritonitis? Is there an anatomic leak? Is there an abscess going on? We want to look at the medical history of these patients. Is the patient has sickle cell disease? The drug history. What drugs has this patient been on? Antibiotics, analgesics, or drugs that elevate serotonin level, or drugs that can cause any other drug reaction, or a patient reactive to sulfur-containing and sulfur drugs. We look at social history of these patients. Alcohol. Is this patient experiencing something of alcohol withdrawal, or is this patient a chronic smoker, which will place the patient more at risk of pulmonary infections? On examination, first, you don't do the general evaluation of these patients. Is this patient ill-looking? It's because you're not just there to just come and see a patient with fever and just give PCM. No. Okay, what actually happened in these patients? Is the patient ill-looking? Is the patient pale? Is the patient with febrile? Is there cyanosis? Is the patient icteric? Is the patient dehydrated? We look at his skin and subcutaneous tissue. Is there an abscess? When you express the surgical wound, there's an abscess, there's pus to come out. Is there necrotizing fasciitis? Is there gangrene of the wound? Or it will be also a bed sore. We want to look at the chest. Is the patient tachypnic? Is there diminished blood cell at any part of the body? At any part of the chest? Any region of the chest? Are there added sounds? Because let's know if there's an ongoing pneumonia going on somewhere. You look at the wound. Is there erythema of the wound? Is there localized edema? Is there tenderness? Or is there discharge of pus? This points to it is a likely surgical site infection. We also want to look at the abdomen. Is this abdomen distended? Is the abdomen tender? Is there rebound tenderness? Is there guarding or rigidity? When we're looking at tenderness, if anyone is generalized with guarding, okay, is this patient now developing peritonitis or other things that can come to your mind as differentials? Oral rectal examination, is there tenderness? Is there purgy mass in the rectovesical pouch? To know if there's actually a collection. We're also going to look at the leg. Is the leg swollen? Is the leg tender along the calf vein? That's the Homer sign. Also look at differential warmth too. All this will point towards a likely deep vein thrombosis going on. CNS, we'll look at neck stiffness or rigidity, photophobia, altered consciousness. To know if there's anything going on in the CNS, be it meningitis or any other cause. Now, after your evaluation, after your history and examination, you now want to run several investigations on these patients to find out what's actually going on in these patients. And I'm taking this based on different departments. For the hematology, we want to do a full blood count and differential, where we're looking at the white blood cell counts, the platelet counts, and also the hemoglobin level of these patients. We'll look at the ESR. Is it elevated or is it reduced? We'll look at blood film also for malaria parasites to point out malaria fever. For microbiology, one day blood culture, is sepsis going on in these patients? You want to do a urine or catheter tip MCS. To know if the patient having a urinary tract infection. One day is putting MCS. Know if the patient has a chest infection. Or even if the patient has an underlying TB going on. Maybe he's a chronic smoker. One look at the stool MCS. Is there an ongoing GI infection? For the biochemistry area, we look at serum, urea electrolyte and creatinine. Now this patient has actually developed a renal issue, maybe secondary from the UTI. We look at liver function test and test for hepatitis B surface antigen and hepatitis C virus. Not if there's a liver pathology going on. If the patient has some of any of these viral infection, which will actually even come from the blood transfusion that was given, if there was a mistake in the cross-matching. Let's look at serum amylase and cardiac enzymes, and also urinalysis too for urinary tract infection, where there will be elevated leukocytes and nitrites. We also want to run radiological examinations. Here we do an X-ray, chest X-ray, abdominal X-ray. And in chest X-ray, we're looking at signs of pneumonia or atelectasis or any collection. Also, for abdominal X-ray, we're looking at I focus mainly on the kidneys, the ureters, and the bladder. We look at joint and bones, if there's anything going on there. Ultrasound, including Doppler, most certainly for deep vein thrombosis. To know if there's a vascular obstruction along the calf. We also want to do CT scan. It could be a chest CT scan, it could be an abdominal CT scan, to know what really is going on with the patient. We want to do an echocardiography or a venogram to know if there's also any cardiac anomaly. For differential diagnosis, depends a lot on the timing of when the fever resumes post-op. Differential could be pneumonia, which is very common, pulmonary embolism as a complication of DVT, wound infections, urinary tract infections, or transfusion reactions. These and several others could be differentials that could be in your mind based on what you have on your evaluation on what is going on with the patients. For treatments, I'm taking on this treatment based on our aims. After I've done the evaluation, I've done your investigations, I have your differentials in mind. How will you treat this patient? You will first resume with resuscitation and control of the fever, then identification of the cause and elimination of the cause. For resuscitation, especially for unstable patients, you won't give respiratory support. Because if you don't actually give a complication that will actually kill this patient before the fever won't kill the patient, when you give respiratory support, even as aspiration pneumonitis, you won't give supplemental oxygen. You won't give supplemental oxygen. You want to suction the airway and position this patient properly. ABCD of resuscitation, educated, crystalloids, colloids, to help expand the intravascular space. Give inotropic agents in emergency conditions, so like adrenaline, if the blood pressure is going so low, or dobutamine. Then general measures for the fever, you will give antipyretics like paracetamol, aspirin, body cooling, especially in pediatric patients where they have to do tepisponging or exposure of these patients. We also want to remove IV lines and catheters and recite new ones. For catheters, if the catheter is causing more harm than good, it can be removed. But even though it's still necessary, it can be changed to a condom catheter. One place on NPO and also do NG tube decompression, especially post-abdominal surgeries, somatic leak, or if an abscess has developed, to ensure that to reduce the complications that may ensue from this condition. Other specific measures is treating the underlying cause. With malaria, give anti-malaria, you give blood-sparing antibiotics, you withdraw the offending drug. If a patient reacting to a particular drug, you withdraw it. Or if it's a blood product, you stop the blood transfusion. If there's pus, you drain the pus or the hematoma or the seroma. You have to institute proper wound care, and also you also supplement heparin. Complications that may arise from post-operative fever. Complications arises mainly from failure of diagnosis to identify the severity, and this leads, and that is, if a patient comes down with post-operative fever and it's not really clear in our mind what's actually going on in this patient. If by the time we're giving antipyretics and the patient is still having an asomatic leak and pus accumulation, this patient comes down with complications. Or patient having another, maybe DVT, and when the DVT is not figured out, patient will come down with complications like pulmonary embolism. So that's why diagnosis of the cause and identification of severity too is really important. And these complications could include sepsis, or sepsis, severe sepsis, septic shock, prolonged hospitalization, increased morbidity and mortality. Preventions. As a means of prevention, it's very important to note that we should discontinue catheters as soon as possible. Also, for passing central lines, it's better using a subclavian line than a femoral line, because the femoral region is more likely to be infected than a subclavian region. You also want to do daily spontaneous breathing exercise, that is chest physiotherapy and incentive spirometry, especially post-thoracic surgeries, like cardiothoracic surgeries. This patient should start incentive spirometry use even prior to the surgery and also after the surgery to enable lung expansion and prevent infection. You also want to use enteral feeds when possible in place of total parenteral nutrition, because TPN is more at risk of infections. Adequate safety measures during blood grouping and cross-matching of blood to avoid blood transfusion reactions or other viral infections that can be transmitted through poor blood screening. In most patients, post-operative fever is due to benign causes and resolves spontaneously. Non-infective causes generally have a better outlook than infective causes. Prognosis still, outcome of infective causes is dependent on the rapidity of identification of the cause, the appropriate resuscitation measures being taken, the appropriate antibiotics being given, and appropriate surgery to eliminate the cause. As a means of conclusion, post-operative fever or post-operative pyrexia should alert the clinician to possibility of complications, but it is not a reliable indicator of infection, and its absence does not guarantee that the patient is infection-free. These are my references. Thank you.
Other drug reactions, you mentioned MNS. What is that?
You spoke about serotonin syndrome. Please, can you just talk more about that?
Malignant neuroleptic syndrome. As I mentioned that as one of the drug reactions that could occur in patients that will give rise to post-operative fever. Malignant neuroleptic syndrome is actually a rare but life-threatening idiosyncratic reaction to neuroleptic medications. And it's actually characterized by patients who come down with fever, muscle rigidity, altered mental status, and autonomic dysfunction. This syndrome, as I say, is caused by neuroleptic drugs. And these drugs primarily used to treat maybe psychotic states. And these drugs actually could include risperidone and risperidone. It also here is quetiapine. And other drugs, there are also other neuroleptic drugs that can actually give rise to this malignant neuroleptic syndrome. But the cardinal features he's in here is severe muscle rigidity. There's hyperthermia, the temperature is above 38 degrees Celsius. There's autonomic instability, and there's change in level of consciousness in these patients. So when the patient is exposed to some of these drugs, and the patient is susceptible to malignant neuroleptic syndrome, they can come down with key symptoms. And one of it includes the hyperthermia with temperature of above 38 degrees Celsius. Now, on the second question, which is another drug reaction that will occur in patients post-op, is serotonin syndrome. The serotonin syndrome here is actually a similar drug reaction. It's caused by medications that build up the level of serotonin in the body. What I'm talking about here is that serotonin syndrome can occur when you increase the dose of a certain medication which the patient is on, or you start taking a new drug. And it's most often caused by a combination of medications that contain serotonin. Some of these medications will include migraine medications, antidepressants, even some analgesics and antiemetics. Like some of these drugs include, like for the analgesics, codeine, tramadol, hydrocodone are included here. But for tricyclic antidepressants, we're looking at the amitriptyline that we can give for an anxious state that having difficulty in sleeping, or nortriptyline. Also, other drugs here can include the selective serotonin receptor inhibitors, like the fluoxetine, the paroxetine, and also other medications too. Even some retroviral medications like the ritonavir. Patients can be on maybe as a patient on a background retroviral medication like ritonavir, and post-op is being given something like cocodamol, like containing codeine, and patient is also anxious. Then I add also amitriptyline. All these combination of these drugs that contain serotonin, that can elevate serotonin in the body, can make the patient come down with serotonin syndrome. And especially when you have a good history of a good drug history, the patient is on this, is on this, is on that, and all of this can cause elevated serotonin in the body. They now point out, oh, this patient actually the fever is actually coming from serotonin syndrome.
I just have a comment that in post-operative fever, I think this is when we need to pay close attention on the microbiology. That's for blood culture in the patient. In that most times post-operatively, the patient is still on antibiotics and the patient is coming down with fever. So at this point, you might want to check out antibiotic sensitivity to know if the patient is actually, in addition to identifying what is causing the post-op fever, we might also want to take note of the blood culture sensitivity to know if we might need to switch our antibiotics to something else, or or remove whatever may be causing the fever at that time.
How you place the causes, like you're switching wind and water, there are days. Usually wind is the first day within 24 hours and 2 days. Not what you said. Then water follows 2 to 3 or 5 days. Then from there, you now have 5 to 7 days and greater than 7 days. The others, your wonder drug and the wound itself. So probably you should look at that and rearrange it again. Then your definition is also okay, but I think the temperature is days. When you get it 2 consecutive days, and when it's 39, greater than 39, 1 day. That is what you define as post-op pyrexia.
Classifying it based on timing, you mentioned, I think immediate, acute, subacute, late, if I was not mistaken. But another classification can be, sometimes some people use weeks, some people use days. It can also be immediate, which is within the first 24 hours, early, which is between 0 to 3 days, late, which is between 3 days to 30 days, and then delayed, which is after 30 days. And then for the causes based on the immediate, you can mention, yes, I think you mentioned as a consequence, like a metabolic response to trauma, that's consequence of the surgery itself, where some people are more prone, and then depending on the severity of the surgery, some people may have a fever reaction immediately, and then of course with blood transfusions like you mentioned. You didn't really talk much about malignant hyperthermia. You mentioned it in passing, but that's one of the most common causes that can happen, even though it's rare, for immediate post-op fever, which is actually life-threatening. I think for the residents that are present, this topic can come out as an oral session in your national. They can just ask you to talk briefly on it and then follow up. Your Viva station, post-op fever is very common, so you have to understand the pathophysiology of malignant fever, how to manage it, and the drug of choice for treatments. Then also, when you were talking about prevention in your topic, you mentioned, I think you were talking about, using subclavian rather than femoral. But you must always remember that for prevention, it starts from pre-op evaluation. A proper pre-op evaluation would reduce your incidence of post-op fever. So in pre-op, you want to identify anything that can cause catastrophe post-op. That's the whole point of your pre-op evaluation. So you finding out from your history taking, it's not just the symptoms you are collecting. You want to find out if the patient has previous comorbidities that will make them more susceptible to infection or to post-op fever. You want to find out if they've had previous surgeries where there has been incidences. Of course, anybody that has had maybe a malignant hyperthermia from previous exposure to anesthesia should be identified before going for a second surgery, so that kind of thing doesn't happen again. And then as well as your smoking, drinking, any form of immunosuppression or anything that will predispose them to having post-operative fever, as well as your examination, your general exam, your systemic exam, as well as also with your investigations, your full blood counts, for patients that are diabetic, their glycated hemoglobin, you want to see what their sugar level has been like, so that you can identify. So that's the key thing when you're talking about prevention.
I don't know whether mention was made of, alcohol withdrawal syndrome or, drug withdrawal symptoms. That can also cause fever. Or was that mentioned?
Yes, he mentioned it now.
Okay, that's good.
In the evaluation, you didn't really mention the blood culture, which you need to take cognizance of. And also what Dr. Naomi mentioned about the pre-op state of the patient. You understand? Also, intra-op conditions, ensure you maintain strict asepsis during surgery, and then post-op care of the patient. Then when you were talking about also in the workup, you didn't mention anything about doing the urine MCS, especially for a patient that's been on catheter. So it's part of the septic workup for post-op fever. So you should remember to take the cultures, the blood culture, and then urine culture. And then also probably you could swab the wound if there's evidence of discharge of pus from the wound. But by and large, you did well. It's commendable. Well done.